So I want to start off by saying good afternoon to everyone. My name is Melanie Cavalier, and I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. So the MHCC is pleased to present the MHCC-MedChi 2024 Spring Forum using data to manage patient populations as part of our Learning Network initiative. This event marks the 18th learning event over the last 3 years. The sessions aim to enhance knowledge, skills, and competencies of practices to deliver equitable, comprehensive, patient-centered care. This event is being recorded. The format for today's event is intended to promote an interactive conversation. To join the conversation, you may raise your hand or enter your thoughts and questions into the chat. I'm going to start off by telling you a little bit about MHCC. MHCC is an independent state regulatory agency that supports advanced care delivery and practice transformation. We collaborate with payers and providers to transition to quality-aligned, value-based care and to harness the potential of data in facilitating meaningful change. Next slide, please. This slide outlines important information about CME credits and disclosures. Following the event, attendees will receive an email that includes a link to a questionnaire. The questionnaire requests feedback on the forum and an application for CME or continuing education credit. We would appreciate your feedback even if you're not applying for CME or CEU credit. Our event planners, reviewers, and speakers today have no disclosures to report. Next slide, please. So today's learning objectives include identify data available in CRISP reports that can be used to manage patient populations, understand how ambulatory practices use the data to enhance care delivery, and recognize actual practice-level improved patient outcomes from using data to manage patient populations. Next slide, please. So this is our agenda for today. We're going to start off with opening remarks from Jean Ransom. Then I'll provide an overview of the current Maryland landscape and MHCC practice transformation activities. Next, we have our 3 speakers to discuss their perspectives on the main topic. We'll hear from Audrey Speeder, a subject matter expert from HMetrics, and Dr. Maura Holton from AA Urology, and Dr. George Bone from IC Care will provide practice perspectives. Both Doctors Holton and Bone participate in the Advancing Practice Transformation program that you'll hear about later. Dr. Bone was in round 1 and Dr. Holton's in round 2. Next slide, please. So I'll now turn it over to Jean to proceed with the opening remarks.
Well, I just wanted to briefly say, and I want to make sure we have time to get into the meat, but we really appreciate the partnership we have with the Maryland Healthcare Commission. MedChi is the Maryland State Medical Society. We're the 7th oldest medical society in the United States and have over 9,000 physician members and provide services to another 10 or so thousand physicians as well. We think that this work that we're doing with the Maryland Healthcare Commission on practice transformation is really important. As you know, Maryland has a unique total cost of care agreement with the federal government, and we are leaders in the country in value-based care. And programs like this one and the transformation grant that I think Melanie's going to talk about a little more later on today are opportunities for physicians to align with that unique model and to provide a higher level of care focusing on costs and outcomes and better quality for the patients. You could not have a better group of speakers to talk about the importance of data. Audrey from HMetrics is in the thick of all the discussions around these types of data discussions, and HMetrics is a major partner not only for the Maryland Healthcare Commission, but also the HSCRC. Dr. Holton is one of the preeminent urologists in the state of Maryland and is in the EQUIP program, the Episode Quality Improvement Program with Anne Arundel Urology. And Dr. Bone has been involved, the past president of MedChi actually, but has been involved in all types of value-based care programs. Most currently, he is in the Maryland Primary Care Program. So they all understand the importance of data and the importance of working together to try to improve outcomes and manage costs. So this is a really important presentation we're doing today, and we really appreciate having the opportunity to partner with the Healthcare Commission. So without further ado, I will turn it back over to Melanie, who is going to make some comments on state initiatives, and I will stay tuned in to listen to the terrific presentation that she's put together with her team. Thanks again, Melanie.
Oh, thank you so much, Jean. So next slide, please. So I'm going to just do a snapshot of the Maryland landscape. So we have 6.18 million people, and 16.9% of the population is 65 and over. Next slide, please. So I want to provide a brief overview of MHCC practice transformation initiatives that are designed to support the Maryland model goals that Jean mentioned by readying practices to participate in value-based care models. Population health management is a key of those models. Next slide, please. Advancing practice transformation has been an MHCC strategic priority for more than a decade. Maryland law tasked MHCC with implementation and management of the Maryland multi-payer PCMH program from 2011 through 2016. The MHCC-MedChi and the University of Maryland School of Medicine, Department of Family and Community Medicine partnered with the New Jersey Innovation Institute to complete practice transformation activities in Maryland as part of the Transforming Clinical Practice Initiative from 2015 to 2019. This was a federal initiative that included over 124,000 clinicians. The MHCC also contributes to planning and policy development for the Maryland Primary Care Program since its inception in 2017. Next slide, please. So I want to let you know about our Health Equity Roundtable and what that led to. So the MHCC convened a Health Equity Practice Roundtable in March of 2022 with representatives from advanced care delivery practices to identify challenges and opportunities for practices seeking to address key health equity concerns in their communities. The goal was to advance health equity in ambulatory practices through the development of practice resources informed by the roundtable feedback. The feedback informed a health equity symposium in March of 2023, which focused on strategies for identifying patterns of need in the community, building referral networks for services related to social needs, and connecting patients to resources. More information on the HE Roundtable is available on the MHCC website at the link on this slide. Next slide, please. So the MHCC manages an advancing practice transformation and ambulatory practice program that we mentioned earlier. The MHCC released an announcement for grant applications in May of 2021 to identify a care transformation organization, or CTO, to engage primary care and specialty practices in a practice transformation program. The grant objectives include preparing practices to deliver efficient, high-quality care while improving outcomes and setting the foundation for practices to provide team-based, patient-centered care. Next slide. In June of 2021, MedChi CTO was competitively awarded a grant to complete practice transformation activities. A crucial role of MedChi CTO is providing practice coaching on specific transformation topics and approaches, such as quality improvement, and tools to help sequence and manage change essential to succeed in a VBC model. The program milestones include a readiness assessment, workflow redesigns, and training. Approximately 45 practices completed round one in June of 2023. An additional 27 practices are projected to complete round two by June of 2024. We are still accepting applications for this program, so please reach out to me if you're interested. Next slide, please. So the MHCC convenes peer learning network events like this one in collaboration with local and national healthcare leaders on topics such as health equity, advanced care delivery, and practice transformation. More information on learning network events is available on our website at the link on this slide. Next slide, please. So two recent events include the Health Equity Symposium I mentioned earlier, and the evolving role of social workers in team-based advanced care delivery. Next slide, please. So now I'm going to turn the presentation over to our subject matter expert, Audrey Speeder from H-Metrics.
Thank you so much, Melanie. I appreciate the opportunity to speak with everybody today. I am Audrey Speeder. I'm the Director of Healthcare Policy at MHCC-MedChi. We provide healthcare business intelligence consulting services, and we partner with CRISP to support their reporting and their data needs across all of their affiliates. I have about 20 years of experience in healthcare economics and policy research, and I've been working across several agencies in the state of Maryland for the last 7 years. In today's session, we're going to be focusing on the tenets of population health, and we'll be talking about the importance of data in managing patient populations. Next slide, please. So as a brief overview of what I'm going to cover over the next few minutes, we'll start with a brief introduction to population health, and then we'll be talking about the phases of population health initiatives. So these are really the 4 phases or the tenets of successful initiatives. We will then be focusing on a case study of Health Quality Partners, which is one of the most successful population health initiatives under a CMS demonstration. We'll be looking at the best practices that have been realized from there, and then we'll bring it back to Maryland and talk about some of the services provided to Maryland through CRISP. Next slide, please. So to get us kicked off on what population health is, population health is generally defined as the health outcomes of a group of individuals and their distribution of outcomes within that population. So there's a real focus on the health outcomes themselves and the patterns of the health determinants for that population, but we really need to consider what policies and interventions are in place that link those outcomes to the health determinants. So there's been a real push for population health, and the need has really been increasing in the most recent past, and that's due to 3 growing trends in our society. First, we've had an increase in the prevalence of chronic conditions. Beneficiaries are presenting with more chronic conditions and are presenting earlier with chronic conditions, and generally it's a more clinically complex population. Associated with that, we've had an increase in healthcare costs. And accompanied with that, we have had a decrease in health status relative to prior generations. So across the board, there's been a need to look across the population to understand what the health outcomes are for that population and what is driving those outcomes. So data is super critical for that, and we'll be covering that today. Population health has really become even more critical as we look towards value-based care instead of a fee-for-service environment. CMS's initiatives have really pushed this value-based initiative. They've been trying to get a large population or a large proportion of Medicare and Medicaid beneficiaries enrolled into value-based care as opposed to keeping them in fee-for-service arrangements. So under a fee-for-service arrangement, there is an incentive providers to increase care, increase the touches with patients. You provide a service, you get paid for a service. There's a direct incentive there for more care. But instead, there's a big push towards value-based care, which is going to provide more holistic care for the population, looking at the patient, looking at what services need to be provided, and what care can be provided to increase those outcomes without that transactional relationship of fee-for-service. That certainly can't be done without the breakdown of our care silos and being able to look across our spectrum of care. So no longer looking within the 4 walls of a hospital, no longer looking within the 4 walls of a skilled nursing facility or a physician's office. It's breaking down those silos, looking at the population across the care continuum and looking at the population beyond individual patients. And certainly by breaking down those care silos, you're incorporating interdisciplinary care teams. And that's really needed to identify and mitigate a broader range of risks that cannot just be addressed by a single specialist or a primary care visit. Next slide, please. So there's several components of population health initiatives. There's these 4 components that are really critical to successful programs. First is that the public health initiative needs to target a population in need of care. So this is looking at patients who have risks. These are either going to be unmet risks or under-recognized risks, and being able to associate those risks with poor outcomes. And from there, we need to also be able to identify populations that can have a care model or can have an intervention that would meet that need. So in identifying a population health initiative, you need to understand what you're trying to do, what is the risk population you're trying to target, and what is the care model that would be able to address that need. The second component is improving the focus of focus for care management initiatives. This is being able to identify risk patterns and being able to identify opportunities and then target the population through care management. Third, we have containing a management system. This is where data are. This is what makes us most happy, is making sure that you have the management system and you have the data to ensure the reliable delivery of a care model and be able to track the progress over time of the program. And our last component is identifying social determinants of health, or SDOH. What are the determinants that are leading to health? What are the determinants that are leading to outcomes? So you're able to identify them and try to meet them with the interventions. So data is really critical to all of these. And on the right slide, we identify that data are not a one-size-fits-all situation. There is no one single data set that's going to meet the needs of all population health initiatives. And it's really important to pair the data, the correct data source, with the correct initiative. So here are just a few examples of the variety of data sources that are available. Starting with the claims, this is effectively an administrative record that a service was rendered. So this does not contain the robustness of the clinical data, but is very excellent in being able to just track the services that have been provided and link them together temporally over time to understand what has happened in the patient's experience. We also have the electronic health record, or the clinical data. This can be a variety of clinical inputs that are consumed there, very helpful as well. There's also medication histories and lab results that can definitely inform a lot of these processes, as well as socioeconomic data. So socioeconomic data does not need to be at an individual patient level. It can also be done at a geographic level. So understanding the socioeconomic construction of the geographic area where residents reside, as well as personal socioeconomic characteristics of individual patients or of a population, a subpopulation. And our last data source being patient generated. Incredibly helpful to get patient-generated data. This can either be individually patient submitted, so this could be a patient completing a survey or a patient interview, but it could also be physician or clinician assisted patient-generated data, which could be an assessment that is that's being completed on activities of daily living, or other patient-generated data that is gathered with the assistance of clinicians. Next slide, please. So now let's cover the phases of a successful population health initiative. We have this outlined as 4 steps, but this is actually a cycle. And I think that cycle element's really important, and we'll come back to it a little bit later in this presentation. So to get us started, the first phase of a successful program is the design phase. This is your opportunity to design a system to identify and mitigate the target risk for the population of interest. So once you understand what the risk is you are trying to address, you can design a model around it to make sure you have the appropriate interventions, to make sure you have the appropriate understanding of what the risk is and how you intend to meet that risk. From there, we get into targeting, and this is where this is the first real step of data. This is a data-driven approach to identify the patients who could benefit from that program that you've just identified. So you need to have the data to identify the population, but you also need the data to facilitate the outreach and the coordination that you need in the subsequent phases. And you also need the data to be able to track the status of those initiatives to make sure they're working okay. So the one statement that could undermine basically this whole presentation is data is critical, 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 but it cannot be done alone. So it must be acted on in order for the initiative to be successful. So again, data is critical to the success of the programs, but in and of itself, it's not enough. You need to have those engagement and you need to have those implementation phases be successfully accomplished as well. So on to the engagement phase. This is where you have active engagement between patients and the program, either the care management team or the clinicians involved in the program. Once you've targeted the patient population that you think can benefit most from your population health initiative, you then need to engage them to get them into the program. I would say this is possibly the most challenging part, but also the most critical. If you do not secure that engagement and you do not get the patients really invested into this intervention, there are challenges with success. And our last phase here is the implementation phase. So this is when you are ensuring that you are operationalizing your program reliably, that all clinicians have a similar approach, you have reliable implementation across everybody involved, and that you are able to identify risks, you are able to modify behavior, you're able to slow disease progression, maintain quality of life, all of the attributes of your program that you're trying to accomplish. That is where we are seeing those measures of success. Now, as I mentioned, this is really a cycle. So in your implementation phase, if you have the appropriate data and the appropriate reporting to track your status of how you're doing over time, you are able to get those mid-course corrections identified to keep you on track. So if you recognize you're not seeing the outcomes that you intended, or you do have some unplanned variation in the way that it is being implemented, you can course correct and you can loop back to the first step of the design. You're able to say, okay, I need to change something in my design process. Let's start back at the beginning of our process. Let's tweak anything we need to. And then you start the cycle all over again, possibly targeting different beneficiaries, possibly going through additional engagement steps, and getting back through implementation of your revised approach. So it is a very iterative process. It is a very living process. So I would say everything needs those 4 steps, but the number of cycles of those steps is really up to the initiative itself. And next slide, please. So now let's talk about what works. I want to highlight for you a case study of Health Quality Partners. Next slide. Health Quality Partners is a nonprofit research-oriented organization. They are based in Pennsylvania, and their focus is to design, test, and disseminate scientifically validated systems of preventative care. They have implemented the Integrated Advanced Primary Care Model, IAPC, and the focus of that model is to identify beneficiaries with complex chronic conditions and be able to maintain their quality of life, address their complex comorbidities while improving their outcomes. HQP and HMetrics have worked together over the last decade or so, and we have developed a web-based platform with them called Sparrow. And the focus of Sparrow is to support their practical and operational tasks of their care management. So it's a web-enabled platform. It's a little tablet that goes with all the clinicians around when they do all of their patient assessments. And it is a very intuitive way for the clinicians to record the data, to understand, to get the input from the patients and track their progress, record what their interventions are, understand what's happening with them. But it's also a way for them to get notifications from the system of any care management needs. It's a way to ensure that the relationship is kept intact between the patient and the care management and the clinicians. One of the most successful attributes of this system is a series of pre-designed reports. And what's important is that these pre-designed reports are not a one-size-fits-all, as no data are. It is 3 levels of reports that enables different people on the care team or different people within the initiative to get the information they need to evaluate and constantly determine the success of this program. So first we have the program level reports, which is at the highest level. It is showing if the program is improving care quality of the enrolled population. So overall, what is the trajectory of the hospital admissions over time? What are the trends of the preventable quality indicators or the PQIs? So at the highest level, how are they doing on outcomes and how are they doing on costs? One step below that in granularity are the management level reports. And these are assessing the reliability of the program implementation to identify unwarranted practice variation. So when I mentioned earlier, you need to make sure that the intervention is applied reliably. You need to make sure that everybody on the care teams and everybody involved is using the same approach and is following the design of the model. The management tools help you understand that. They help you understand if there's any variation in process that needs to be addressed. And last, at the most granular level, you do have the patient data. You have the patient level information. Population health is all about the population overall, but it is of course made up of patients, and you need to respect and understand each patient's experience. So this is a way to track the outcomes for individual beneficiaries, and be able to link their outcomes with something going on in their life. Was there a behavior change? Was there any life changes? Or was it just the implementation of the program? So now we understand that you need to have the spectrum of reporting. Let's now look at how HQP fared with this. So HQP's integrated advanced, next slide, please. HQP's integrated advanced preventative care model was an MCCD. It was a Medicare coordinated care demonstration. So CMS had a demonstration that awarded 15 programs funding to design and implement various interventions for Medicare fee-for-service beneficiaries. Their goal was to provide funding to 15 different programs, and they said, you tell us what works. You show us what you're doing. We are going to evaluate if it works, and we are going to use that to identify best practices for population health initiatives. Mathematica Policy Research was commissioned to conduct the evaluation of this. And it wasn't just that they were following these models over time. They were doing retrospective cohort studies, randomized controlled studies, where there was the study population and a controlled comparison group, so they could really make sure that they're isolating the impact of the program. HQP was identified as the only MCCD participant to be successful among high-risk populations. And you'll see in this highlighted quote that HQP was very data-driven. They're tracking care coordinators' performance and continually assessing the effectiveness of newly introduced intervention components and refinements of existing ones. They implemented that feedback cycle. So they got through the implementation phase. They were able to identify those process variations through those management reports, and we're able to loop back and say, how do we need to change this to make sure that we're able to achieve our goal? On the right side of the slide here, these are the 6 tenets that Mathematica have identified to be the best practices for these population health initiatives. You need to have face-to-face care manager contact. With patients. You need to have face-to-face care manager contact with physicians. Evidence-based patient education, management of care setting transitions. You need to facilitate communication across providers, and you need to have medication management. Data has a really nice home in all of these to be able to support these initiatives in one way or another. Next slide, please. So let's look at outcomes. I want to draw your attention to the Washington Post article on the slide here, and this is really the kind of the quintessential sentence that people think about who are familiar with HQP. Washington Post released an article with the headline of this: "If this were a pill, you'd do anything to get it." It was really identified as kind of the bellwether initiative that was able to use data to produce outcomes over this population. So Mathematica found that HQP uses a much more data-driven approach to manage patients in the program itself than the other MCCD participants. So through their data-driven approach and through the use of their platform and through their tenets of best practices, they were able to achieve a 39% reduction in their annualized hospitalizations for high-risk beneficiaries, a 36% lower Part A and Part B expenditure, which was $500 per beneficiary per month, a $397 lower Part A and B expenditures after fees. And this is actually really critical because it's one thing to be able to kind of bend the cost curve and reduce the total cost for a population. It's another to be able to do that while offsetting the cost of these programs. These programs are not insignificant. They are typically very expensive to run. So to be able to still achieve healthcare savings while netting out the cost of the program is pretty remarkable. And then in terms of long-term outcomes, they demonstrated a 34% reduction in all-cause mortality over 5 years. All right, so that's a quick snapshot on health quality partners. Now let's bring it back to Maryland. So if we can jump to the next slide, please. We can go one more. So let's talk about Maryland and let's talk about its relationship with CRISP. So as I mentioned, HMetrics partners with CRISP. We provide analytic and reporting services for Maryland. And there are several statewide initiatives across the state aiming to reduce cost and aiming to improve outcomes. Maryland relies on CRISP to provide the data services to operationalize these programs into get data into hands of the participants so they can achieve the desired outcomes. We need to make sure that there are data for everybody involved. We make sure there's data for care managers, make sure there's data for clinicians, and make sure there's data for program administrators. So there's several different programs, several different needs for the data, and the data needs to be accessible for all the different players here. So this does come back to the phases of the population health initiatives that I covered. The data analytics available through CRISP enable the targeting of the population, they enable the engagement of clinicians, and they support the tracking of the program to make sure all of those mid-course corrections are able to be identified. Next slide, please. So in the state of Maryland, there are several voluntary programs, and many of them have been adapted from national initiatives. There's been a real evolution of programs over time in the state, whereas at the beginning of kind of the value-based population health initiatives, the programs are fairly prescriptive. So when we're looking at CCIP or the Chronic Care Improvement Program, or even the Hospital Care Improvement Program, HCIP, around 2017, if not earlier, those programs were fairly prescriptive in that people understood what they needed to do. Participants understood what they needed to do. They understood, they were able to easily identify who the populations were that would be appropriate for these programs, and they were able to identify the interventions and implement that. But as kind of time goes on, there's been an evolution towards kind of more of a choose your own adventure type approach to ensure that population health initiatives match the strengths of the providers. So we got into the ECIP, the Episode Care Improvement Program, which is focusing on a hospital admission and the post-acute care that follows. So really looking at the bundle of services of once a patient gets admitted to the hospital, let's cover the care in the hospital and let's cover the post-acute care that follows. Streamlining those transitions, streamlining those handoffs, making sure those silos are broken down and that a patient is looked at holistically. From there was further evolution towards the Care Transformation Initiatives, or CTIs. This one I would say is truly a choose your own adventure approach. This is a really interesting program where participants are able to register with the state the interventions that they are currently doing so that they can get credit for those initiatives and participate in shared savings. So it's not prescriptive in what the intervention or the program needs to be. Participants are able to say, what are we doing right now in our four walls that we think is working, or what are initiatives that we want to be doing? Sign up as a participant and be able to participate in the program and do tracking that way. So that's ongoing. That started in 2021 and is getting bigger every year. There are more thematic areas being identified even as we speak. There's also the MDPCP program that I know Dr. Bone will talk to a little bit later this morning, looking at advanced primary care for Medicare fee-for-service beneficiaries. And then EQUIP, which is an episode-based program, but outside of the hospital, looking in the ambulatory or the community setting. And last, as we all look ahead, and no pun intended, to the Advanced All-Payer Health Equity Approaches and Development, or the AHEAD model, that I know Maryland is considering, which would go into effect in 2025 if awarded. So there's a huge variety of different voluntary programs across the state, all of which need a variety of different data. Participants have different needs under each of the programs, and CRISP is working to support these in the best way they can. On the next slide, there are some mandatory programs. I don't want to overlook these. These are generally more hospital focused. You have the SIHIS, which is the statewide integrated health improvement strategy, which is an overarching program for the entire state. But the other mandatory programs are more financially based. They're looking at the financial impact to hospitals, and they have that hospital purview. So they're looking at hospital acquired conditions, looking at quality-based reimbursement, readmission reduction, or avoidable utilization. Next slide, please. So let's talk data reporting. There is a variety of ways to use data to support participants across all of these initiatives. There is a need this is where CRISP really comes in. There is a need to make sure that the clinicians and the care managers have the data to target the beneficiaries and to track their population health initiatives. So as I mentioned, CRISP partners with MHCC-MedChi to provide a lot of these data-driven tools. And one tool I want to highlight briefly for you today is the newest suite to be added into the repertoire, which is the multi-payer reporting suite. This is the first reporting suite within CRS that includes more than one data source, more than one payer source at one time. So this reporting suite includes both Medicare and Medicaid beneficiaries. It's an administrative claims data set. So it's taking the Medicare claims and the Medicaid claims, putting them together and presenting them within a single reporting suite. So users of this suite are able to upload a panel of patients of interest to them. And if they're Medicare and Medicaid together, they're able to see the trends in the utilization for that population at one time. So the multi-payer reporting suite reports are highlighted in the center of your slide here. Most of them are utilization focused. We're looking at acute care setting, so just the use of hospitalizations, emergency room utilization, readmission utilization, PQIs, or the prevention quality indicators, looking at avoidable hospital admissions, and follow up with physicians following inpatient discharge. There's also a report that focuses on the payments associated with that, so the per member per month trend report, looking over time to see how the healthcare spending for that population is fluctuating. And then we turn to health equity by having health equity by demographics reports, focusing on the clinical and demographic characteristics of the population to identify if there's gaps in care, to identify if there are any disparities between your population by age, by gender, by race, by ADI or area deprivation index, or other metrics like that. And then we round out our suite with maternal health utilization, looking at prenatal and postpartum care, and CMS core set measures that are of interest to several participants as they want to be able to track directly with the CMS measures that they are held accountable to. And next slide, please. So one of the main attributes of the multi-payer reporting suite is a population navigator view and a use of rosters. So when we're talking population health, we do want to be able to talk big picture, but we also want to be able to get down to an individual patient. And as we mentioned on the first slides of what the phases are, is you need to be able to target your population. So that's where Population Navigator comes in. It is a mechanism where you're able to see all of the patients of interest to you, or all of the patients that you load in a panel, and be able to select them or customize a subpopulation based on demographics of interest, either clinical or demographic or even utilization. So you'd be able to identify a population that has diabetes and hypertension, or you'd also be able to overlay on top of that those that live in a certain area or are of a certain race, or of a certain age band. And you're able to customize the view and whittle down a little bit at a time until you identify a subpopulation that you want to focus on. So it really helps in the targeting of who you want to focus on for your population health initiative. And what's unique about this is once you've identified that subpopulation, you can save it as a roster, and then that roster is able to be loaded in all of the other reports. So instead of looking at your full panel of patients, you can isolate it to only be the subpopulation that you identified in your roster and look at trends specifically for them. Next slide, please. So one of the major tenets of a lot of the CRISP reporting is the importance of flexibility. So all of the reports generally allow you to get to different levels of aggregation depending on your needs. So the reports start at the population level. They start at the highest level of what is the overall trend, but they enable you to then drill down to a beneficiary level and then be able to drill down even further to a claim level. So in a quick instance here, this is just a snapshot of our emergency room utilization report, and we're focusing on emergent ED utilization versus non-emergent ED utilization. And let's say I'm interested in a data point here of the non-emergent ED visits for this specific provider that I've highlighted. Once I have identified that population and I say I want to learn more, if you go to the next slide, you're able to drill through and look at the patient details. Who are the individual patients that are contributing to this data point? Who are the individual patients that have experienced a non-emergent ED visit? I want to know their name. I want to know their demographics. I want to know who they are. Just, really put a face with a name type of situation. So this helps users really get underneath that trend of what's going on. We then take it one more step further on the next slide, that once you've identified an individual patient, you can then get into the claim details. So what happened in this patient's healthcare journey that led to this non-emergent ED visit? You can see all of the claims. Several of our reports have a 3-year history, so all of the claims over the last several years. You can sort by inpatient or ED or other services to be able to put together the story. This can be really helpful from a care management perspective. Are there experiences that the patient had that you may want to be able to interject early on next time to avoid that non-emergent ED visit? And of course, everything is exportable, so analytics don't have to be completed within the suite. They are able to be completed within your native environment in your facilities. All right, on the next slide. One attribute I want to just cover is that the importance of comparison groups in all of the data. So it is important in a lot of the CRISP reporting that we give people context. It's not enough to say that your inpatient admissions have grown by 5%. What happened elsewhere? What happened outside of those walls? So a lot of our reporting suites offer comparison group trends where you're able to look at the state overall. You're able to look at an overall program, such as the MDPCP program, or you're able to look within an individual payer. How does my Medicare trends for my subpopulation compare to the overall Medicare trends in the state of Maryland? So we make sure those comparison groups are available, and it's really important to rely on those because absent of that context, it's really hard to interpret these data points. Next slide, please. So let's actually wrap up. If you can go one more, please. And we can wrap up with some quick conclusions. So population health initiatives around the country have informed best practices. And it's important to take those best practices, learn from them, and implement them in the development of future programs. And data's really the cornerstone of the cornerstone for success for these initiatives, but it cannot be operated on alone. We need to have the robust care model design. We need to have engagement with clinical teams and patients, and we need to have the methodical implementation of program interventions. So data in and of itself is a really great first step, but it certainly cannot get us all the way through it. We need to have those other attributes of the program. And of course, data is not a one size fits all. We need to pick the data set that works best for our initiative, and that needs to be incorporated into flexible reporting that allows data to be used by a variety of users. Whether it be administrators, care managers, or physicians, they need to be able to act on it and secure that engagement with the population. And of course, those comparison groups are really helpful to identify that. So with that, I want to say thank you so much for joining me this morning. Appreciate your time and attention. If you have any questions, feel free to reach out. Be happy to answer questions at the end of the session. Melanie, I'll turn it back to you.
Yeah, thank you so much, Audrey. So that was great. Really appreciate all the detail that you went into and showing those screenshots so people can see where to get the information. So I'm now going to turn it over to Dr. Holton from AA Urology, who's going to tell us a little bit about how she uses data in her practice.
So good afternoon. Thank you for inviting me to participate today. And Audrey, thank you for that presentation. I think from my vantage point, having seen that presentation a couple of times, the big takeaway is that there has been tremendous evolution, refinement, and really, impressive degrees of sort of winnowing of data so that we can use it in our clinical practice settings. So, I really think that Chris provides a tremendous amount of resources. What can be challenging and overwhelming is figuring out how you can use those resources and how you can interact. So I'm Mara Holton. I'm the managing partner and CEO of Anne Arundel Urology PA. We're a large single specialty GU group in Maryland. And I've been really interested in the possibilities associated with data for a long time, but the translation to making this meaningful for an independent practice in particular has been really challenging. Obviously, we don't have historically access to sophisticated data analytics or sophisticated statisticians and those sorts of things. So again, this has really been a process, and we've made a couple of halting efforts, and I'll talk to you about what we've done. But again, I do think I've been particularly excited seeing what sort of data is sort of available out there, basically for free, and how we can start using that more meaningfully for our patient population. Next slide. So one of the things I realized right away is that while I know we have the capacity to collect lots and lots of data, using that diligently, responsibly, and effectively in a private practice setting is tremendously challenging. Again, I can't repeat enough times, we just don't have the bandwidth typically in our practices, nor the sort of depth of expertise that it takes to use this material well. So we can collect the data, but if we don't know what we're collecting or why we're collecting, and if we're not collecting it in a way which is responsible or reasonable, we're not getting much that's worthwhile. Next slide. So, again, to sort of parlay off of what Audrey had said, in our practice, when I try to evaluate how I can sort of assess a small data analytics project, and I really want to emphasize here that everything we do in the context of our practice is very myopic. We're GU specialists, and then we start from GU, which is giant, and then, relatively, and then, winnow it down to prostate cancer, winnow it down to advanced prostate cancer, winnow it down to patients within an age range. Because if you bite off more than you can chew, you get overwhelmed very quickly. Questions always arise as to where to collect that data. Are you collecting it from an EHR? In our case, typically you are. Are you collecting it from a practice management system? So again, where are you getting your data? And that really needs to be tailored to the questions you're trying to answer. Who and how to get the best information. So again, Audrey referenced whether you're doing patient surveys or patient facilitated information. I think most people are probably migrating away from purely patient reported information. I think, again, it's really important to reference here that this is not going to be a, one-stop shop, one fits all, and you are going to have resources within your practice who are dedicated to this. So we use data which we collect from our EHR, and we also use lots of patient facilitated data. And then what does it mean? So interpretation of the data, how do you respond to that data? What do you change with that data? And that all bypasses the fact that, again, this is an iterative process. So at what point do you stop, reevaluate, decide if the metrics you've chosen were correct? So I don't want to understate the complexity of these processes. Next. So in our case, as I mentioned, we chose what's called APC, or advanced prostate cancer. And I show this prostate cancer pathway slide, not because I expect anyone to memorize it, since you can't even read it, but because it is so extraordinarily complicated. So prostate cancer, we identified as a pathology which has gotten really exponentially more complicated with treatment alternatives in the last decade or 2 decades. So both from a provider vantage point and from a patient vantage point, certainly cancer patients in general, but again, this is an elderly cancer patient population typically. So we certainly felt like this was a patient population that was at risk of falling through the cracks. Previously, this has been identified as a patient population where demographic factors, and I don't know that this isn't true for almost all malignancies, have significant sort of impact, socioeconomic factors, those sorts of things. So again, that's why this was appealing. And then well-established outcome metrics. So we are not inventing the entire wheel here. We are, I mean, honestly, we're at fine sanding paper at this point. So the APC community, Society of Urologic Oncology, the ABU, the AUA, all of our national organizations have really given us very, very rigid or certainly comprehensive guidelines as to how we metricize anticipated outcomes and protocols. So we're really able to look at our patient population and benchmark it against what we believe is a standard of care. If we had to define that standard of care, it would be far beyond the ability of our practice, or I imagine any independent practice, to do so. Next slide. So in doing advanced prostate cancer, as I mentioned, there is a pathway-driven clinical care protocol. So again, we've got these large national organizations that have any number of sort of guidelines. We spent quite some time putting those together in a way which was particular to our patient population, our workflow, those sorts of things. We elected to use a combination of data collection from lookbacks in the EHR with clinically specialized staff who understood what data points we were looking for, and then patient-facilitated surveys and survey information. We used outreach mechanisms both in person, so at patient appointments, as well as via phone and text. And again, I can't say enough about having dedicated staff who understood the complexity of this disease process and the specific needs of this population. And then again, the measurable outcomes that we determined for our practice were getting us closer to benchmarks that we felt like were national averages. Next slide. So I cannot emphasize enough how critical it is to have a vendor partner. I will candidly tell you that, you know, when value-based care came out, I jumped into my EHR and I thought that, you know, I would just fiddle with the data and I would solve all of the world's healthcare problems. That's a little bit of hubris. So data is cumbersome. It's cumbersome in any number of ways. Audrey talked about that at great length. I reiterated it. EHRs are notoriously finicky and idiosyncratic, and I will add proprietary. So EHRs do not like to spit information to you for free. So it is challenging both to get EHRs to give information which is good, to give information which is correct, and to give information which isn't, you know, a bloody fortune. And again, generally private practices have limited specialized staff. So we don't have statisticians on staff. We have IT on staff, but the sophistication of your IT certainly isn't the sophistication level that you would find at a metrics type organization. So there are lots of challenges in doing this. And I'm agnostic to the vendor partner you choose, but I will say there has been really an explosion of vendor partners in the last 5-7 years, a number of whom I think are really quite good, who can help you work with your EHR vendor, with your practice to identify benchmarks, goals, priorities that make sense, and then communicate in a language that perhaps you don't have to the IT companies, the EHRs, to get the data that you need to get the job done. Next slide. These are just examples reference to what I spoke about, which is this limited survey impact in advanced prostate cancer. This is not the only data-based initiative that we are doing. We have some benign disease processes that we're looking at, but in this case, we looked at the survey impact of what's called an oral oncolytic survey. This speaks directly to what I referenced, which are the changes in the paradigm of treatment for advanced prostate cancer, which now includes oral drugs, which had formerly been administered intravenously. So in this case, we had about 100 surveys completed, about 10% of those patients were not getting what's considered optimal standard of care oral therapy. And of those, about half were started on an oral oncolytic. So I mean, I actually thought this was extraordinary to have a 10% rate of patients who were on truly kind of a anachronistic modality. That's not where we want to be. And this enabled us to change that. Next slide. You know, this really just demonstrates that we're trying to utilize other features within software to reach out to patients. I personally find that the asynchronicity of telephones is really a challenge. So I don't want to make recommendations for any individual practice. There are HIPAA guidelines which govern your ability to text. There are waivers that have to be obtained. There are any number of things. So these are not recommendations which pertain to any individual practice, but we have been able to use SMS texting features again with appropriate HIPAA, patient waiver, and acceptance, really to be pretty efficacious in our ability to communicate with patients, because people can respond to text in an asynchronous fashion. The information can go back into the EHR, and then the provider who is responsible for supervising that information can respond asynchronously. So unlike a phone where you've got to get two people available at the same time, this has really been remarkably more effective. I will say, of course, you know, we certainly have patients who do not use texting, particularly elderly patients, but I will say that is becoming fewer and fewer. People are really, really, really adopting this technology because it is so extraordinarily efficient for communication. Next slide. And this is an example of what we defined as very large general patient outcomes for 2023. What is important about this, and Audrey referenced, is we don't have a benchmark because we had never done this before. So we've been trying to come up with patient outcomes for many years. And, you know, we've had a bunch of dipping our toes in this. But in this patient population, we set a couple of metrics. These are only some of them, to ensure that all patients had a next appointment, identify cancer progression, and identify novel treatments that we were not offering to patients, which were guideline driven. So what we will now be able to do is look at how we do in 24, presumably improving. I can't tell you that we didn't do better in 2022 before we had this kind of navigation and data analytics in place, but the presumption is that we did not, because the belief is that we are identifying these patients sooner. And sometimes, you know, in lieu of losing patients, we've all, you know, sort of had the scenario where there's, I mean, a vast population of patients, and I don't know about you, but I can't keep 10,000 patients in my head concurrently. So there is no doubt but that people get lost in the ether for a whole variety of reasons. They get admitted to a rehab, family situations change. So, you know, from things as simple as that can completely pivot treatment, it's really pretty extraordinary to finally be able to use data in a meaningful way. Next slide. So I mentioned we have lots of other metrics. Again, I don't specify, I'm not explicit here, but we identified symptoms which were improved. We identified new treatments. We have patient satisfaction scores, detection of cancer progression. That's really a very particular one. I think that, again, many of these modalities are critical to initiate at detection. And we all know that there can be just massive delays. A patient's got a 3-month follow-up, they cancel that visit, it's 3 months later. This really does enable us to order imaging if that's what's needed, order lab work if that's what's needed, and really follow up on those things in much more real time. So this is a month in review. We do these analyses monthly, and this is the kind of dashboards that we're looking at. Very simple, very easy to look at global reaction. And again, we have staff who's dealing individually with every single one of these patients. Next slide. What's next? Well, obviously, we want to broaden the measures that we're looking at. I mentioned that we have some others. The benign disease process that is sort of nearest and dearest to my heart is overactive bladder. That's a modality or a pathology that has been treated with drugs, which we know have some pretty untoward side effects. So the goal is to identify those patients, get them off those drugs, identify if people are in fact having side effects. So we are working diligently on that. And then, of course, ongoing refinement and data collection, that is absolutely an iterative process. And that is the kind of thing where, we have to come back to the table every 3 months, every 4 months to look at whether the data we're collecting is answering the questions that we wanted to ask. And honestly, candidly, maybe our questions have changed in the interval because of some of the information we've collected. So there's a lot of adaptability and change within this process. And you really have to be willing to be wrong. I have certainly had some presumptions that were not borne out by the data. And you really have to have a team who's flexible and willing to work with you. And I will say both a vendor partner and your staff as you're determining what data points you're collecting and how you're looking at them. Next slide. And I think that's all. So feel free to reach out to me by email. And I think we're taking questions at the end. So I'll be happy to answer any questions anyone has.
Thank you so much, Dr. Holton. It's so important for us to be able to hear how practices are actually using this data and, how that is improving the outcomes for patients. So we appreciate your sharing that information with us today. So at this time, we're going to turn it over to Dr. George Bone from IC Care. And Dr. Bone, just to do a time check, we have about 27 minutes left, but I would like a couple minutes just at the end to close out. So what we'll do is we'll see when you end, and then if I need to, we'll collect. I can collect the questions and send them to the speakers. So thank you, Dr. Bone, and I'll turn it over to you now.
Thank you very much for this opportunity to show what we've been doing here at IC Care. If I can have the first slide. IC Care is the next slide. IC Care is a small solo practice, one part-time physician, one part-time nurse practitioner. We have about a fluctuating population on the care of approximately 2,000 patients per year. It can go up to a total of 4,000 to 5,000, depending upon the insurance they cycle in and out, but still consider us as their physician. The age range is 21 to 97, average age of 65, with about 19% greater than 78. It's an African-American population, primarily insured. Medicare at 70%, commercial at 27%, a small amount of Medicaid. Located in Prince George's County, which is primarily an African-American county, 60 to 70%, with approximately 10% uninsured in an overall unemployment environment of 2 to 3%. The importance of underscoring unemployment is that it means that 10% of the population chooses or is unable to afford insurance, which means they'll be subject to episodic care, which is higher costs and more unpredictable. The surrounding counties are shown here: Montgomery County, Anne Arundel County, the District of Columbia, with the color scheme: blue is Caucasian, orange is Black, brown is Hispanic, and gold is Asian. Just to show you that even though the state is heavily 55% Caucasian, we are an African-American county predominantly, and with the bordering neighboring counties being different in terms of population makeup. And the mortality at birth is expected at 78.5 years in the county, compared to the state of Maryland, slightly lower and slightly higher than the national average. Again, the context in which you view data and collect data is very important, so that I'll keep re-emphasizing that throughout the conversation. And these are the sources from which we get our data, fairly self-explanatory. But the big thing is, next slide, is this number at 4.25 trillion. That's the US healthcare budget in 2023, plus or minus a few $100 billion. And so this is a mother load of data. And how do we normally come to grips with this? As a primary care physician, the next slide, we are usually bombarded with where is the money spent in a hospital, personal spending by patients at 16%, physician services by 14%, prescription drugs, and we're usually asked to reduce these costs, primarily by reducing hospitalization. When Dr. Chen looked at these numbers, he said that we could reduce administrative costs, we can reduce drug spending, and we could pay physicians less. In that these are the drivers of healthcare costs compared to other industrialized countries in Europe, Japan, and Korea. Next slide. Question is, what does a doctor do with this information? One of the rather than looking at the where and what this money is spent, we might look through the lens as to who and why. And in actual fact, the sickest 5% of the population consumes 50% of the total healthcare costs, and the healthiest 50% only consumes less than 3%. So the next slide. So looking at this through the lens of disease has actually been very helpful for me. And when we look at what drives disease, you can look at the genetic history, you can look at physical security, clean water, environmental factors, balanced nutrition and lifestyle. And here in the US, we are all survivors. We come from a very strong genetic stock. All of us got here either by walking, as the Native Americans did, from the Bering Straits all the way down to the tip of South America, or we came here by boat via the Middle Passage, or we came here by plane, all survivors running from something. So genetically, it's not a significant contributor to our disease population, other than the fact that we are selected to survive on minimal food resources, currently living in great abundance. The Commonwealth Fund looked at security and estimated that this contributes less than 1% to our ill health. We incarcerate danger, so that physical security is not a significant problem by and large, although like clean water, we have pockets of insecurity. The environmental factors have reduced, primarily because we've exported a lot of our manufacturing. Air pollution and living next to factories remain a problem. So we're left with nutrition and lifestyle. 80 to 86% of our healthcare costs are due to these two factors. So it gives us a lens from which a physician could approach this problem. Next slide, please. Our overall approach is actually easy. We use data to try to keep our patients healthy. And by process measures, efficiency measures, outcome measures, and then getting reporting back as to what the total cost of care is. The next slide. The process measures that we look at are the BMI, or bone density, cancer screening, colon and breasts, efficiency in terms of how we how do we reduce the disease burden, our medication adherence, immunization, nutrition optimization, and treatment outcomes we primarily focus on are blood pressure control, hemoglobin A1C reduction, and BMI reduction. Next. The one example of a data group is our MIPS data. The MIPS data set comprises 182 patients attributed this most recent quarter, and it's broken down into between low risk and complex risk. And you can see the risk spans from 0 to over 4.6. Now, if we can go to the next slide, this actually points out the importance of graphic display of the data set to allow you to start to tease apart the data. When we look at this, we see that the tiers, tier 1 spreads over ages 63 to 79 with an average age of 7 to 1. And as we go through the tiers, we can see that the average age goes from 7 to 1 to 8 to 1, but in our most complex, it's actually 7 to 9. So we can see that the average age is not giving us much information. So, but if we look at the age range, we see that tier 1 gives us an age range of 63 to 79, while all the other tiers, the age range is much wider. So from this, we can conclude that tier 1 is somewhat more homogeneous a population than the other tiers. So again, this forces us to really ask questions, since this data is coming from the outside and it is our patient population. We know more about our patients than most do. The other thing to realize that this is also retrospective data, so that persons could be categorized as being very ill, but in actual fact, they were ill, but currently they're not. So if someone would have had a major illness, a subdural hematoma or a motor accident, they might be in tier 5, but when you actually look at them, they might not be in the appropriate tier. The importance of looking at this with a sharp eye, it allows you to work more efficiently rather than having to look at the entire population. But suffice it to say that it would appear that tier 4 is similar to tier 5, both in average age, so that one would be most concerned that tier 4 patients are patients who are in the process of deteriorating into tier 5. So great attention needs to be placed on tier 4 so that you would slow their descent into costly care. But next slide. But how is a physician to actually deal with this? As a primary care physician, we have 6 tools to affect disease manifestation and cost of care. The first and most important is accurate diagnosis. Wrong diagnosis or no diagnosis leads to inappropriate care. The second is infectious disease pushes the vulnerable to the edge and over the edge, depending on their immune system and organ system reserves. So that's why immunization is very important. The third is nutrition optimization. We are a selectively overnourished population geared to survive in undernutrition environment. So obesity and selective malnutrition abounds in the society. So seeking this out and correcting it is an important tool in our armamentarium. Medication compliance. If your patient does not take your best guess treatment, they are not in your data game. The treatment outcome monitoring, if you are not measuring what you're doing, you don't really know what to correct. And last but most important is workflow efficiency. Next. As far as efficiency goes, we have inculcated key performance indicators in all of our medical assistance reimbursement bonuses, which I'll touch on in a little while. But a significant problem is the amount of time a physician has to spend data gathering and inputting data. And if any physician is spending 2 to 4 hours after his workday ends or her workday ends to complete the record, it is not conducive to optimum healthcare or to reduce burnout, a big problem. Next. To facilitate efficiency, we have standing orders for vaccinations and standing orders for hemoglobin A1C frequency, eye examinations, bone density, and colon cancer screening, so that these orders could be executed by chart reviews, and actually it pops up. So it's done without having to go through a physician to get it executed. This is just a quick next slide to show the KPIs of physician workload and allergy identification for each given medical assistant. Next. And we also use our telephone monitoring to identify frequency of phone call receipt, who returns phone calls. We also utilize automated calling and manual live telephone interaction with patients to really remind them of appointments, to solve problems when they occur, and to be able to identify which of our team members are actually doing that work. Next slide, please. We use MIPS for reporting and Immunet for immunization identification, in addition to our internal system. Next. And this is an example of our immunization reporting. We're doing excellent as far as flu vaccines, 90% completion rate. And we have now started working on zoster, Tdap, and pneumonia, which is now being included as a bundle in reporting to MIPS. Next slide. For breast cancer screening and bone density, we're doing, compared to the expected standards, we're doing very well with 86% mammogram reporting, colon cancer screening at 83%, and diabetic eye examinations. And we have to do better for osteoporosis bone density screening, but expectedly doing very well with the documentation of current medications and BMI screening. Next. These are the agencies. We use CRISP and MDPCP to report our outcomes. Next slide. And we chose hypertension because it is such a prevalent problem in America and in the African American community. Basically, CDC reports that the blood pressure control in African American community is terrible and can be improved. And this is our goal. Next slide. This is a snapshot of the hypertension prevalence in the practice. Currently, 1,700 active patients. We have a prevalence of hypertension depending upon how you want to define it. Less than 130 over 80 at 48%, which compares nationally to the African American population at 58% hypertensive with only 17% controlled. Next. And when we actually look at the degree of control, we are at 60% control, less than 140 over systolic, and compared to the control population of 17%. So that really what the importance here is having a system flexible enough to allow you to vary the definitions of hypertension. We all know, that the definition is getting progressively tighter, so that the control population will get harder and harder to accomplish. But with the million heart comparison of 140 over 90, we were actually doing very well. Next slide, please. When we look at our MIPS reporting, MIPS has us identified with 593 hypertensives. We were actually at 68% control, which again is looks fairly well. Next slide. When we look at our diabetic population, we have approximately 414 patients that are both diabetic and pre-diabetic, with defining control as A1C less than 7. We have approximately 68% of our patients controlled. And next slide, please. And only 9% uncontrolled with an A1C greater than 9. When we go to the next slide. When we go to the MIPS reporting, they only have a population of 284 patients with diabetes, and their definition of control is greater than 9, and we are at 6.54% uncontrolled. Again, they are not including the pre-diabetic population, and part of the issue with their definition of diabetes is if you have someone who has been diagnosed with diabetes and now you have them totally controlled with A1C less than 5.7, you can sometimes miss them within the within their catchment pool. Next slide. In closing, we are at a very very critical inflection point in our ability to predict and engineer complex biological systems, which I think is going to transform healthcare from a wet and messy art/science into an engineering discipline. This is being driven by these four major converging innovations. One, precision genetic information, advancements in deep learning, cost reduction for collecting healthcare data, and understanding the socio-demographic basis of disease. As exciting as this is, it's not going to be easy because life, like medicine, is complex and hard. But I think this will be of great benefit. Next slide. I'd like to thank all who have contributed with all of these resources. Population health is a team sport. And the data gathering by the staff at IC Care is without doubt one of the main reasons that we can do this. The mastermind graphics, MHCC helped with the slide deck, and office manager Kieran Bowen-Dormier for coordinating the team, Rochelle McFall helping with the data, and Chris and MDPCP and MIPS and all the staff from ZH to really help us to both have comparison populations, but just to wrestle data to the ground to deliver health. Thank you very much.
Thank you so much, Dr. Bone, for sharing how you're using data in your practice. And I love to see, especially a smaller practice like yours, talk about how they're using some very sophisticated techniques. So we are close to time for today. So if people want to send me their questions, I'm happy to send them to these speakers. As I close out, I just want to say that the recording and the slides will be posted on the MHCC website. My contact information is here on this slide. As a reminder, you're going to receive a questionnaire in the next couple of days. Please fill it out. It is a requirement to receive the CMEs or the CEUs. And a special thank you to all of our speakers and to you, all of our attendees. And I hope everyone has a great day. Thank you so much. Bye, everyone.
Thank you. Goodbye.